All right. Good morning, guys. Josh Lumley. I'm the Vice Chief Medical Officer for North Star Anesthesia. I'm happy to be here today to talk to you about geriatric anesthesia and aging. As I've alluded to on previous lectures, there will be information that is shared in this lecture that has some overlap with other lectures, specifically the respiratory lecture, probably your cardiovascular lecture, your renal lecture. So any topics that appear multiple times over, do keep those in the memory bank because it is something that we feel is important, and in all likelihood, it is something that the board feels is important. So let's go ahead and begin. I don't have any financial disclosures to make. So we're going to talk about background on the elderly population, the changes that occur to them. So obviously what we see, and we hear this over and over again when you turn on the news, is that the elderly population, the 75 to 84 population, 65 and up, as well as the octogenarians and even the 90-year-olds, that population is increasing dramatically. Right now, it's 12% of the population. That occupies a third of all of our surgical procedures are done on those over 65. So they also represent a third of healthcare expenditures, and over half of our healthcare budget is dedicated to 12% of the population, that being those over to 65. And what we see is there's going to be a dramatic increase between now and the mid-2020s, and then even worse in the 2030s. So what is the overriding principle? If you do anything, if you get anything from this lecture, it is that baseline level of function of most of the organs is totally preserved in the elderly population. But the gray area, the control, the ability to tolerate decreases in blood pressure associated with induction of anesthesia, the ability to tolerate the cerebral vascular effects associated with decreases in blood pressure, the ability to tolerate hypoxia, that area is much, much smaller. Okay, so you've got a narrow window of opportunity beyond which you sort of fall off a cliff. So the long-term discussion is basically to say start low and go very, very slow. What is the median age of the U.S. population? And it's just over 40 years. So population growth is 15.1% in those over the age of 65, 30% in those 45 to 64, and what we see is in the younger age group, that population growth is marginal, if not just flat. So the long and the short of it is the elderly population is a population that we are going to be taking care of and are going to comprise more and more of our patients in the future. So continue to expand. By 2030, 1 in 5 are going to be over the age of 65. Obviously, there's going to be a disproportional distribution of hospital-based resources on this population. Again, most of our patients are going to be elderly. So what is aging? You know, obviously we know that when we think back to our second year of med school, when we started our first SOAP notes, we would always include that patient is a 67-year-old patient that appears stated age. So just because a person is 80, they could be very, very functional, and a 55-year-old could be very, very poorly functional. We all know that there are disparities of what is aging. So normal aging is harder to characterize. So it's a confluence of both genetics, diet, lifestyle, and environmental exposure, all of which contribute to aging. But what are those changes that can occur across the board in both healthy and non-healthy elderly populations? What are the changes associated with the cardiovascular system? Which of these are cardiovascular changes in aging? And the answer is E, all of the above. So cardiovascularly, these patients have a widened pulse pressure. So diastole stays pretty normal. They have an isolated increase in systolic blood pressure. They have baseline ventricular load that's increased due to left ventricular hypertrophy. So they do, in fact, have diastolic dysfunction, which makes them less tolerant of extreme, large infusions over rapid periods, over short periods of crystalloid. So the LV filling is more dependent on the atrial kick. All of these are going to increase the likelihood of CAD, of left atrial enlargement, and CHF, and death. Cardiac output, starting at the age of 30, decreases by 1% per year. So what that means is by the age of 80, you're going to have a 50% decrease in your cardiac output from when you are 30 years old. What are the other cardiovascular changes that occur with elderly? So number one, they have hypertension, not just related strictly to their left ventricular hypertrophy, but they also have increased arterial wall thickness, decreased arterial wall responsiveness, and increased systemic vascular resistance. Again, I mentioned left ventricular hypertrophy, so there's increased afterload both from the increased arterial wall thickness, as well as just general age-related changes. So as that left ventricular wall thickens and you get LVH and impaired relaxation, you also put that patient at elevated risk for subendocardial ischemia. So myocardial oxygen demand alters, and it becomes more dependent on diastolic filling, which of course, as we said, is impaired. Ventricular remodeling and just scar tissue development, as well as fatty depositions, speed up diastolic dysfunction. And then finally, the heart itself becomes much less responsive to catecholamines. So these patients tend to have bradycardia, which results in a physiologic beta blockade. Even though I mentioned that, the systolic cardiac function tends to be preserved with age. So there is a maximal decline of the heart rate due to this physiologic beta blockade, as well as increased vagal tone. So while there is diastolic dysfunction, you do have a physiologic beta blockade, you have increased vagal tone, so you have increased time in diastole, which does actually help to preserve the myocardium. However, there is development of autonomic dysfunction, and that's accompanied by an increase in sympathetic activity. So you've got some modulated increased vagal tone, but you've got autonomic dysfunction in some of these patients, which is going to offset that. And baroreceptor control of the heart rate is now decreased, and that contributes to this dysfunctional regulation of blood pressure. The elderly have what? Obstructive pulmonary disease, restrictive pulmonary disease, neither, both, or it depends. They typically have a restrictive pathology. So what are some of the changes that we see in our patients that have with age related to the respiratory system? So overall, there's worsened chest stiffness, there's increased work of breathing, and there's decreased maximum minimum ventilation. This is combined with the fact that their lungs overall have decreased lung elasticity. They have over-descended alveoli, which according to Laplace's law means that we have differential ventilation increasing in the apices of the lung. We have collapsed smaller airways, so we have worsened dead space ventilation at the apex, and we have worsened shunt at the bases, and then we have an increased residual volume and closing capacity, all of which worsens shunt and worsens VQ mismatch. Then you combine that with the fact that overall they have a decreased cough reflex, decreased ciliary clearance, which we often see in our smokers as well. They have an increased accumulation of secretions, which puts them at higher risk for pneumonia at baseline, but also in the operating room puts them at risk for perioperative pneumonia. Looking at the skeletal changes, we do see some kyphoscoliosis, which occurs, which while the histopathology of these lungs may look somewhat normal, that means that they have decreased excursion and expansion possibilities, which creates a restrictive pathology. Changes in aging include increased synthesis of neurotransmitters, increased skeletal muscle innervation, increased complexity of neuronal connections, all of the above, or none of the above. None of the above. So in the CNS, these patients overall have cerebral atrophy. They have decreased complexity of the neuronal connections and decreased synthesis of neurotransmitters. Now, because of their cerebral atrophy, that can put them artificially, because of the Monroe-Kelly doctrine, and they have decreased cerebral volume, they have normal blood volume, and they have normal CSF volume, can put them far, far down the road and be better able to tolerate a cerebral vascular insult such as stroke or hemorrhage, which is both a benefit and a curse, meaning that when elevations in ICP appear, it could be very, very far down the road in terms of their cerebral vascular accident. They have increased fibrosis of the peripheral sympathetic neurons, decreased skeletal muscle innervation. They have decreased strength and decreased fine motor control. And overall, across all modalities, they have decreased perception. So their renal system, it changes dramatically. So renal mass decreases. They have decreased renal blood flow, decreased GFR. Now, one thing to consider, though, is they have normal or decreased serum creatinine. Why? Because they have decreased muscle mass. So in our elderly population, do bear in mind, I'm just saying if you had sort of a board question that said creatinine is 1.4, what is the impact of that? So creatinine of 1.4 is, while it's elevated in a normal adult population, in an elderly population with low muscle mass, that indicates substantial renal insufficiency or failure. So even slight elevations in creatinine to 1.1 or 1.2 can be reflective of significantly impaired renal function. So what does that mean for our anesthesia care for these patients? So because of their decreased renal blood flow, because of their decreased renal function, they're at significantly increased risk for both fluid and electrolyte imbalances. We're not very good as anesthesiologists of being able to assess where we are on the fluid spectrum, whether it be too low or too high or optimal. So in this patient population, you would have a low threshold for an invasive monitor such as a esophageal Doppler to assess left ventricular filling and to assess stroke volume. They're at increased risk for acute renal failure, and bear in mind these are already dysfunctional kidneys, so knocking off a few nephrons can be quite catastrophic to these patients. Obviously, you want to make sure that you have adequate perfusion of the kidneys and that you're optimizing urine output, and titrate your drugs carefully and titrate them according to an impaired renal clearance. Kidneys, they're exquisitely sensitive to diminished blood flow from a hemodynamic standpoint. So in these folks, extended periods of hypotension are going to have a very adverse effect on renal blood flow. So acute renal failure is responsible for 1/5 of all mortality associated in the perioperative period in elderly patients. So bear in mind, we've got to perfuse the kidneys, we've got to protect the kidneys. Geriatric patients, they're much less able to tolerate hypovolemia, but on top of that, they're much less able to tolerate hypervolemia. So remember, in the hypovolemia type phenomenon, we start looking at the risks associated with end organ failure, of hypoperfusion. On the hypervolemia side of things, we start to think about CHF, we start to think about pulmonary edema, and that window of opportunity of perfect fluid balance is much, much smaller in our elderly population. For suspected hypovolemia in an elderly patient, 1 or 2 liters of crystalloid can be given gradually. Again, think back to that first slide where we talked about the need to go slow with anesthesia with our elderly population. The same thing goes there because of that stiffened left ventricle. They're less able to tolerate extreme changes in volume status. So here we have a robotic procedure in steep Trendelenburg position. We have an insufflated abdomen where we may be having decreased preload in the heart, and a lot of our patients that are elderly are the ones that are undergoing these robotic procedures with robotic prostatectomies and robotic TAHs and BSOs. So in the absence of invasive monitoring, if the patient is profoundly hypotensive, you may grab for blood or colloid earlier in the game than you would grab with a healthy patient, because a healthy patient would be better able to tolerate extreme and rapid infusion of crystalloids. So again, high volume normal saline can cause a non-anon gap hyperchloremic metabolic acidosis. So in this case here, if you have to give them a lot of fluids for maintenance, you may want to consider half normal saline. What about the GI and the hepatic system? So again, brain mass decreases, renal mass decreases, so not surprisingly, liver mass decreases, and hepatic blood flow decreases. The function of the liver from a synthetic standpoint, it worsens. So albumin decreases, the production of our synthetic clotting factors, so our synthesized clotting factors 2, 5, 7, 9, and 10 is going to be decreasing. The metabolism of drugs is going to slow. So that can be plasma cholinesterase levels are decreased, gastric pH is going to rise, and we may see smaller gastric volumes than younger patients. So what is the change in our body composition? So while some of these folks may appear smaller in mass and decreased muscle mass, they actually have an increase in body fat. So they have a decrease in skeletal muscle mass, which is why a change in creatinine is so, it could be even worse than expected. They have decreased intracellular and total body water while maintaining intravascular volume. So obesity and the elderly, we've talked about a patient population that now has decreasing muscle mass, increasing obesity. Now you've augmented that, you've made it worse, and you've increased the body fat even worse. So it can worsen the incidence of sleep apnea, worsen comorbidities such as hypertension, hypercholesterolemia, arthritis, and then it adversely affects our anesthetic management of these patients. So obviously, increased fat stores are going to increase the volume of distribution for our lipid-soluble drugs, so they may have a prolonged effect in that in these patients. Obviously, the decreased skeletal muscle mass is going to decrease the amount of maximal heart rate, maximal oxygen consumption, and it's going to correspond to a decrease in cardiac output and a decreased ability for heat production. So these patients are going to be very, very susceptible to hypothermia and temperature changes intraoperatively. Obviously, those that have an increased plasma volume, not specifically intravascularly, but total body water, may have an exaggerated response to drugs if you dose them by weight alone.